Hello, everyone. Welcome back to the Ellington Ballroom for our final breakout session of Research Revolution 2025, and what a powerful note to end on. As political and cultural pressures shift how organizations are talking about DEI, it's more important than ever to focus on why inclusive research matters and how to keep equity and access front and center without letting it get lost in the language. Our panelists today will unpack the evolving conversation around diversity in clinical trials, explore what happens when DEI gets de-emphasized but disparities persist, and share practical approaches for designing studies that are truly inclusive in action and not just in messaging. This will be an interactive discussion addressing the real challenges sites face in building trust with underrepresented communities. Please join me today in welcoming Catherine, Rachael, Zoe, and Dell to the stage.
Thank you, Jillian. Thank you, audience, for showing up to probably one of the more interesting panels, and I'd have to say the most color coordinated. I'm actually pretty proud of us. Zoe, you were the only one who did not get the memo, but it's okay. That's why we put you in the middle. Okay, so we are here to talk about reclaiming the why behind DE&I because it rhymes and also because it's important. And I have invited these three panelists up here with me because of their various backgrounds and roles that they play in this space. And I could never do them justice, partially because I can no longer speak English after 3 days, but also because their backgrounds are so impressive. So I'd like you all to go ahead and introduce yourself, starting with Dell here.
Good afternoon. For everybody that's in the panel here, this is the people that you know are truly leaning into this topic. Otherwise, they wouldn't be here. So good to see you. Dell Smith, co-founder and CEO of a company called Acclinate. We focus on accessing, engaging, and mobilizing hard-to-reach communities and communities of color around clinical trial participation. And I'll leave it at that.
Hi, everyone. I'm Zoe Felicie. I work at PPD, part of ThermoFisher Scientific, and my role is focused on helping site partnerships kind of evolve and change and ensuring that we're still keeping equity and inclusion front and center. And yeah, I'm going to leave it at that because we're going to go in a little bit deeper, but it's definitely something that I've been involved in for the extent of my career, starting in academia and now in industry. And regardless of what we're doing, that's not going to change.
Hi, I'm Rachael Fones. I'm Government and Public Affairs for IQVIA. Similar, yeah. Another CRO, may have heard of. And strategic advisor on diversity in clinical trials. My background in this topic actually is much more related to my day job of public policy and government affairs. And this is a topic that I gravitated to when I first joined then Quintiles as a CRO and was doing public policy. And I'm like, wait, we're still talking about diversity in clinical trials? Because it had been 20 years since I had first had this discussion in DC. And so I have spent about the last decade, and I've totally dated myself, involved in different policy discussions with stakeholders about this topic. And as the rest of the industry started to realize this was something we needed to solve, it turned out I had amassed a lot of insight and ideas around diversity in clinical trials. So I've spent the big part of the last 5 years working with sponsors, sites to some extent, and a lot of internal folks on how to improve how we do diversity in clinical trials.
Thank you. So yeah, you guys have all been operating in this space for a minute, right? I think we've all been having this conversation for a long time. I know it's been around for the length of my career and many others in the room. I think it's important now to talk about it more than ever for many reasons, but also because of some of the recent changes in the politics and the dialogue that happens around the word diversity and DEI. I want to jump right into that elephant and just go ahead and talk about it, mostly because Dell and I just came off an event where I heard him give a very compelling speech talking about it's more than just being woke, it's about being wise, and that there's actually science and human cost that goes with diversity and representation. And I wanted to get your thoughts and give you a chance to summarize.
Yeah, I mean, if I had my way right now, I'd say just remove diversity, the word diversity from this topic. And I say that because what I was mentioning, what I was saying at this conference that Catherine mentioned is that, this is all about good data, good science, and good business. And I gave the example for example, when I was defending my dissertation, I came and I put all my data out there and I was defending my dissertation. My dissertation committee came back and said, you're trying to say that what you found is applicable to an entire population that you actually didn't get data to sample. And you've got two choices. Either you can change the title of what you're doing to say, I'm looking at this very specific demographic group, or you need to go back and collect more representative data. And it was really just about, that's what scientific methodology is about, is that if we're going to make claims about a broader population, we need to have data to be able to support that. And that's where I believe we need to get to and stay from a industry, is to talk about this as representative clinical trials. We made that shift last year prior to the administrative change. Let's do it. There's not a lot of people in here. We can lean in. Prior to who's in the White House, we made that change. I know, Rachael, you can't speak like this as well, so I can do it. But we made, because we saw that shift happening, but it didn't change anything in terms of our day-to-day operations and our outcomes. But it did change the way we had to talk about this, our marketing, our messaging. And I was just having this conversation with Zoe. I was like, I believe from what we're seeing right now that we're actually seeing more advancement and for where we sit, optimism. And frankly, that means clients that are leaning into this even more now than they did pre-administrative change. But there was clearly a period of time where everybody was like, what the heck is going on? They kind of pressed pause. But I think folks just kind of said, this is just really about good science. What are we getting all twisted about?
Yeah. Want me to follow up? Okay. So yeah, I agree with what you're saying, Del. I think even at the beginning of the year, end of last year, beginning of this year, there was a lot of worry, a lot of caution. We saw from a CRO perspective, things get canceled, things get put on pause. But overall, I do still feel optimistic about it because it also made us kind of shift how we do things. So maybe it's not like, oh, I have to go to a separate department now and talk about health equity or patient diversity. Now it's like we're weaving that into the other larger processes that were already happening. And that was like our pie in the sky. That's what we wanted to see. It didn't need to be an extra thing that we needed to see out to another department or something like that. So particularly for my role, I transitioned from patient diversity and health equity to strategic site collaborations so that I could keep doing the work, but it was embedded in what the larger team was already doing.
Which is a happy accident, right? Like you said that we had to do it because you wanted to, because there was a little bit of change coming, but ultimately that's how we should function, right?
Exactly.
It shouldn't be something separate. It should be a matter of how we do business. So maybe that is a little bit of a silver lining that's come out of some of the dialogue shifts. Like this is just how we do business because this is how science works.
Yeah. Exactly. Well, Catherine, also I've seen the conversation around diversity in clinical trials, because that's what it got named many decades ago, come and go with administrations. This is the first time previously, the last 4 years, that you saw real traction, right? Like it was, we're going to do, more culturally sensitive brochures was the conversation in 2016. It wasn't around the science. It wasn't embedded. So I think the really good news is even with the name change and the kind of bumps and headwinds or whatever we want to call it. Sorry, that was very corporate sounding. The bumps and headwinds. People are talking about generalizability of data and representation in data. And the FDA is still saying that, right? That's what they're saying. And that is a totally different conversation. I used to have to explain to people that the whole purpose of diversity in clinical trials was fairness of access and understanding your product better. And that's normal part of, used to have to defend that side, and that's gotten traction. So I think that's incredibly good news.
I'm looking at my follow-up script. I'm trying to stay on script because I promised Rachael I would, but then also I'm probably not going to. But I will try my best. So building upon that, though, we talk a lot about, I hear a lot of conversations about building in community and engagement, and that it has to be intentional and it can't be transactional, and that it has to come way before the ask is ever made. And then, of course, we all are familiar with the dialogue too. Then, well, who's going to fund it? How do we finance it? I know that we've all had different models that we've pursued. Rachael, with the work that we've done with Acro and some of the funding around those programs. Del, with you partnering with pharma, and Zoe with your company and what you're willing to do. can you share some tips or guidances on like how we should think about funding these efforts and what that actually comes up to? Because people think of it sometimes as being like massive amounts of money, but sometimes it's not massive amounts of money.
But it does take money. It's funny, when we started our company 5.5 years ago, like our second slide after our title slide was all black background and white letters that said, "We are not a patient recruitment company." And we would just pause, and the pharma teams would be on and be like, "Well, why are we talking to you? Because this is all about patient recruitment." And we'd say, is your current process working for you when it comes to making sure you have adequate representation? And of course, we know the answer for most of that was no. And so for a company, what we said to people is like, we've got to go further upstream to engage with people, not at the point of transaction of, "Hey, Jane, you don't know me, but would you like to be part of a clinical trial?" Like, that doesn't work for a lot of our community members. But one of the things we said to pharma is we said, listen, for us to go further upstream, we cannot still be recruitment and be focused on recruitment and still go, because further upstream for us means that they're no longer just patients. Right? People talk about patient centricity. For us, patient centricity means that at the center of it, the person is a human being. Yeah. And so how do we deal with them on their day-to-day issues that they have around health and being a human being before being labeled as a patient? But what we explain to them is like going further upstream means that we're going to have to engage at different times and points with them. We'll have KPIs, and we're still, so we come to and we say, well, listen, we'll still deliver pre-screens for your study, but we're not going to be tied to a specific KPI on how many of those people actually enrolled in our study. That's for a patient recruitment company. And of course, the magic becomes when we then start to work together in like an ecosystem where we're working with companies that have a greater focus on recruitment to be able to say, hey, look, we've identified people who are willing and ready and able to be mobilized to take part in clinical trials. Now you work with them to help them kind of understand and navigate the consent process and engaging with the sites. But our job is hard enough to go further upstream, but let's connect them together so we understand how the dollars that you're spending for that further upstream work corresponds to ROI for your particular trial. And we're seeing more and more of that, so that's what's giving me optimism.
I think that distinction was always super important, and Del, you and I have talked about that several times, and I was always very adamant when I was talking internally and externally to sponsors about kind of like the work that you all do, and I'm like, there's a difference here, and it has to be very clear. Everybody has, their bottom line, their ROI that they're looking for, but at the end of the day, if you're not building trust within communities long before the ask, what are we doing? Because at the end of the day, we are the community, right? We're all potentially patients or have family members that will be patients. So it's like you have to take that into consideration. And also another thing is building with the community could be a number of different things. It's not necessarily only related to health, right? It could be supporting a PTO. It could be supporting whatever local organization is already a trusted broker in that community and then partnering with them because your mission aligns.
Yeah, that's it. Just the example I've used a lot is like our team came to us and said, there's a coach in a particular metro area that we're engaged in, and he's having a graduation for his little league players, and we want to sponsor the little league tournament, right? Can we do like, or the banquet, like $2,500? I was like, why are we sponsoring a little league banquet? And they were like, because he has said he's so tired of his players' parents missing the games because they're not healthy. And he's going to use that platform to both celebrate the players, but also tell the parents, I need for you to take some actions so y'all can get healthier and you can stop missing your kids' games. And we said, that's the place we want to be in the community to engage that way, right? And then understanding, to your point, that's where the trust starts, and that's what we have to do. Now, if he had gone to a traditional pharma or CRO and said, hey, can I have money to support my banquet? We know what the answer probably would have been, rightfully so. And so we see ourselves as being that person that works at that level of engagement to do that pull-through work.
Well, your model is fascinating to me as a non-operational person who has been hearing, though, these problems for years, right? But I think the very thing you started with, the transactional nature of looking for patients in clinical trials, is at the heart of the challenge that we tried to get at with ACRO. And I know Catherine mentioned that she serves on the ACRO board, and I have the privilege of serving as the chair of the DEI, D&I committee. We change the acronyms from time to time, but we still have those. And what we decided to do, what the board voted to do, was to give these, I think we kind of called them micro grants. We picked, we offered it up, but we had 64 sites of all different kinds and all across the country apply to basically pilot their idea for what, they've often tried to get funding for from sponsors to demonstrate what might work with some funding to improve diversity in clinical trials. And the one that, the person that first approached me and is one of our grant winners, his very thing is, I know I need to engage with the community, and I'm out there talking to this one group of people who needs the healthcare and needs that, but I can't do it all the time. But I can't get anybody to fund it. And this micro grant gave him enough to hire someone. And now that he's hired that person, he can add kind of a line item for community engagement, but it would have never paid for him to hire someone. And I can't wait for us to really publish that model, because we're talking about $50,000 is what he did to hire this person, I think part-time. I'm looking out at our grant manager to see if I got that right. But just the point is, we're not talking $1 million here. We're not talking all the money, if you think back, that was thrown in at the beginning of COVID. When we knew this, there was huge amounts of money, but let's get real. It's in the community. It's the smaller investments that need to happen.
Yeah, I was going to ask to call out, because I know the total amount that we gave in the grant was not that much, but we were able to, we started off with a certain amount of winners, but we got so many applications that were good and just so common sense and such a low ask that we ended up, we did several at the 50,000 and then we did several at a lower amount as well. And how many did we fund in total?
Seven
in total.
Yeah, and one of them was just, their idea was an oncology center. And they're like, we know it was in Nebraska, which I used to think was not diverse at all. So I've since learned. But they wanted to get to know the oncology practices outside of Omaha. And, so there was some rural aspect to it, but also some parts of Omaha that wasn't applying there. And they've, in the last just few months, gotten 30 referrals from other doctors into their practice for oncology trials, which, means it's working. And it was less than 20. It was $25,000. And I think they split that in half for their programming.
Yeah. So that's what I mean when I say it's small dollars. Like, it's still dollars, but it is not. People tend to think of these programs as being, hundreds of thousands of dollars. Our total grant budget was 100, right, for the grants? 150?
No, 250.
250. I lied. 250. But 250,
that was a lot. That's more than 10% of.
Yeah, for the money that we had available to grant, we were able to find 7 centers. I think the other thing I like about what I've heard from all of you, and I know that I was excited that Acro did, is going to the people who are the experts and asking what they need instead of telling. Yeah. I think sometimes we forget that the people on the ground know what's going to be most effective. And so maybe you don't need money to run an advertising campaign or new brochures with different people on them. Maybe you need to fund the Little League, right? How do you recommend people facilitate those conversations, and at what level?
Okay.
No, please, go ahead.
Okay. So are you talking about the conversation about funding community engagement?
Like, yes.
Yeah. So I think those conversations, they're multifaceted, and they have to happen at so many different levels. They happen from the top down, but then sometimes whatever is discussed at that higher level with sponsor and CRO doesn't make it down to the site, right? We have goals and ideas of what needs to happen for this particular protocol, but it doesn't get necessarily communicated down to the site. We all know that. The other part of it is we'll have kind of buy-in from leadership to do certain things, but that's not communicated to the actual study team that's implementing those things or supposed to be implementing those things. And so it doesn't get operationalized at the site level. So I think there's conversations that need to happen at various different touch points, and it has to be in alignment with all of the stakeholders.
It's an excellent question. The other thing that we heard a lot about, and I've heard Del mention it, and I know it was a topic of conversation when we did the Acro grants, is ROI. And so you've already hinted at it on the stage, Del, right? Like, it's not an immediate calculate 1 + 1 = 2 ROI. You filled the funnel, and then you may not see that return on that funnel for some period of time. But let's talk about the cost of not doing it versus the investment up front. You had some great stats in your talk. I'm just going to keep referencing your talk because it's burned in my brain.
Yeah, I do want to talk about the cost of not doing it, but I do want to I do want to lean into the ROI. I think there's a way we can get there. And our client said to us like early on, like we have to figure out a way to tie this closer to an ROI. We understood that, and we didn't try to push away from that. But I'll give you an example where I think it's starting to work in a way that's tangible. So we worked with a pharma client with their particular clinical trial team around a particular indication, and we of course contracted with them around their study. And while we told them we were not a clinical trial recruitment company, clearly they were like, we're looking for anything to give us the best shot of trying to get to our goals. So we're going to work with you. And of course, we did our access and our engagement, our early engagement, and it did not, for that particular study team, for that particular study, yield significant ROI for them. But because we had already were working around that indication, the next study team for that particular indication within that client engaged with us and contracted with us, and all of a sudden that well of people that we had built around that indication in those metro areas that we had sustained engagement over a period of time, when we introduced the study opportunity to them and said, hey Jane, for the last 7 months you've been engaging with us around X, we think you should know that there's a study in your area that you may want to take a look at. Jane was leaning in like, oh my gosh, yes. And so the study team was like, how are you bringing us more people than our clinical trial recruitment companies? And we were like, because the team before you made the investment to do that work, and you're now reaping the benefits from that. And so that particular client just signed a multi-year contract with us, because now they're like, oh, now we see it. Once you start the process, and then you can start reaping the benefits. But to date, we've been so transactional. The progress starts with the study teams, and as soon as the study's over, it stops. And that's been part of the challenge there.
Yeah.
Right, because it's not only just you have to be there at the right time beforehand, but you have to stay there.
Have to stay there.
Sustained and long-term engagement. And just to piggyback off of that, I was going to say, that's what we call return on engagement, right? Rather than the ROI.
Talk more about that.
Yeah, well, I mean, it's exactly what Dell's describing. It's the long game. It's playing the long game. You know, if we're building trust within a community, but then we're coming in and being transactional, that trust is broken, and then it's hard to get it back. You know, he's engaging with that community long before we're asking about being in any clinical trial. We're finding out what their needs are and how do we meet those. And as you said earlier, they know what they need. You know, maybe it's not a cardiovascular outcome study that they need, right? Maybe it's not a diabetes study. Maybe it's something else that's more meaningful to that particular community. How do we serve that need?
Sorry, now I'm going to ask a question, which I know is not my role, but so what always fascinates me about this, though, is as CROs, as sponsors, you can't be in every community all the time. So when you say we, it seems, I mean, maybe I'm about to say something obvious, but, you know, is it helping our sites that we all work with over and over again maintain their community connection? Because again, you know, like we can't be in all of them, and we are transactional. It's just the way the business works. It's not like
Absolutely.
it's the business model. It's not your business model.
Right.
That's why you get
But
hired.
yeah, and I think you're absolutely
ours.
right. We, as the CRO, can't be in every community, but it is us partnering with organizations that can be, right? And how do we not only show the value in the work that they do, but ensure that it can be funded so that it's sustainable and we can keep doing it?
We went to, when my co-founder and I started our company, we went to sites. Like we traveled across the country because we went all these sites and we're like, here's what we want to do, this sustained engagement model. And that way we can bring, and the sites were like, oh my gosh, we love it, we want it. And we're like, cool, here's how much it's going to cost. They're like, we don't have the money for it. Right? And so we looked at this and we actually said to ourselves, like, listen, you know, they were talking to us about working with CROs, and we're like, yeah, we could go to CROs. But at the end of the day, it's the sponsors, right, that need this data to turn it in to get the. So let's just go straight to the sponsors, and that model has worked for us because the sponsors now are allocating the funds to work with the sites, and in this case, even now starting to work with the CROs. But it's just interesting. The people who had the need didn't necessarily have the budget, and to your point, right, they were like, I wish I did, but I can't get this approved. Yeah.
And I just wanted to add on the other side of that, I think it's also important for sites to kind of have a proof of concept, right? If they're already doing things, and I'm saying this speaking from, I came from the site level as well, right? So if they're already doing things that are working and we have actual numbers behind what that looks like, when we show that to sponsor about what's working and what's not working, we have something that we can leverage.
Exactly. Zoe, I wanted to give you an opportunity to talk a little bit about the site engagement work that you do in your role with ThermoFisher. It's a slightly different model, right? Like Rachael is talking about public policy and advocating on the Hill, and like some of the grant work we've done. Dell's doing a community model. How is your company trying to approach this?
Yeah. So when I transitioned to my new team, everyone on my team is therapeutically aligned, but I work agnostically across all of the site partnerships. And basically, instead of us kind of trying to figure out this way to embed diversity into what each of these sites are doing, it was more about figuring out what does diversity look like for your particular site, and not just focusing on the US, but from a global perspective. What does diversity look like for your particular location at your site or for your network of sites? And then being able to highlight those sites that may not get that visibility internally with feasibility, highlighting those sites and also highlighting them for our sponsors, which we know is a little difficult, right? Because if we haven't worked with them and there's not performance data to kind of back up what they're doing, then they tend to be overlooked or inadvertently left off a site list, right? So it was kind of making the case for why we need to go to new sites, new investigators. And recently I've been working on this frontier site framework, right? And that is to help kind of leverage the new investigators that are trying to get into research, but are not getting the opportunity because they don't have 2 years of experience to get on your study.
Excellent. That was great, because I know that would be one of the questions too, right? There's a big emphasis on going to new sites that have access to patients, but then we've heard it over and over again on multiple panels that those sites aren't getting selected. So it's great that you guys are advocating and trying to find ways to highlight that. You also brought up an interesting piece around the global issue, and that diversity isn't just a U.S. issue, that it is a global issue. Can you give us a little bit more color about how that plays out in your world?
Yeah. I think one of the main things is that we haven't standardized in our industry, like what diversity means, right, in different countries. And so we tend to look at it in different countries by place of origin, maybe by their language, or just other aspects of diversity, not necessarily race or ethnicity, right? So we're talking about socioeconomic status, we're talking about rural versus urban, we're talking about veterans, we're talking about women, pregnant women, all of those different aspects of diversity. And so when we're looking at it globally, that comes up even more than the way that we kind of talk about it here in the US.
And that actually leads into a question for Rachael, because some of the work that we do on Hill, right, like I do it part-time, you do it full-time, is trying to explain why diversity and representation matters to different political sets of ears. What advice can you give to people to navigate, or how have you kind of had to walk that line of what diversity really means, and then paint a broader picture that it's more than just DE&I as the way we see it in media?
That's an interesting question. So, first of all, I'm going to say on the Hill, there isn't a need. They actually do still understand it. When Fedora passed with what started with the Depict Act, that had been a process that was underway for some time. And I had the pleasure or the opportunity to speak with the lady that was writing the legislation. I think it was that would have been December 2022, I guess, with a few final questions. And then we went and met with a Republican. He's like, yeah, we got to do something about representation in clinical trials. So again, back to the good news, I think people on the Hill still believe in it. It just has gotten caught up in what you call woke versus wise, like that. It got caught up in that. So I think from the Hill, I think it's more about meeting the tone right now of the politics and talking instead about the importance of the medicines that come to market working for Americans, all Americans. And again, this is the Hill, right? So we're not talking the global issue. Yeah. I think, it's clear we have a real problem here. We have trials that need to be filled. We have sites that are too busy or don't have the workforce. Now I'm really pivoting. The problem is the infrastructure isn't there to deliver on trials as it is in the US, and it's definitely not there to really support representative trials. So I think it's maybe pivoting the conversation less about push the FDA to push diversity and more about help us help the US be better represented in clinical trials.
Yeah, it's interesting you say that, because when you think about tailwinds and headwinds, right, we kind of worked through this headwind of attack on diversity and diversity in clinical trials being thrown in that mix. And our positioning as of last year was like, this isn't about being woke. This is about good science.
Yeah.
But then we entered this new headwind where good science was in question. Right? And I was like, well, I hadn't planned on that one. And so, strategically, we're like, okay, well, how do we address this? And, and it kind of gets down to just this fundamental thing of telling people, like, don't you want the medicine that you have to take to work for you?
Right.
Like, and you kind of get it, we're trying to like get it down to like and something that you can't really argue with in that sense. And that's really so much what this is about, is we just need to make sure that the drugs that are intended to work on the people we want them to work for are safe and effective.
Yeah. Well, sorry, there's just one thing. With the people on the Hill, despite what you see on TV, one of the things, and Catherine, you experienced this, most of the staff that works for the members of Congress and the members themselves, they were like, bring us what's going on and simple ideas or things we can do to address it. That's their like nature. That's what brings them into public office and what brings those staffers to go work for next to nothing compared to what you can make in the private sector. So anyway, I know you had the government affairs panel earlier, but I think as you were, the science discussion is much more not in that realm. Or I guess, I don't know, I was just trying to say, I wanted to encourage sites to think about, that are here, and companies to think about what levers could government pull to make things work better pragmatically.
Yeah, that's a good point. And I'll say, yes, most of the conversations I've had on the Hill is more about explaining data and explaining the reality of what's happening. Surprisingly, I think a lot of the staffers I've spoken to are hungry for examples of what happens when we don't make that investment, right? Like, what is the impact on public health? Mm-hmm. What is the impact on the U.S. economy if we aren't known for the lead in health sciences? And so if anybody wants to write a letter to the congressman, come see me. I've got tips. But going to that, I wanted to pivot back to cost, right? And reframing cost. Because I think when we have this conversation about reclaiming the why, we have to reclaim the cost of opportunity and the cost of on health, and if we don't make this investment. And I wanted to give each of you a little bit of a soapbox to advocate for. How do you define the true cost of if we let this slip?
I guess I'll start. I would say it's less access to safer therapies, right? So at the end of the day, it's not about the optics. It's about access to care and access to drugs and devices that we know are safe and efficient. So I think one of the main things that if we're not going to kind of use diversity or any of the buzzwords, it's like we need to focus on the principles of why, and really understanding that at the end of the day, this is what we need to stay relevant in science and to have that good science that we can rely on, and it affects everybody.
Yeah, I think there's a macroeconomic cost, there's microeconomic cost, and then you have the financial cost and you have the human cost. I mean, it gets really be interesting. More and more I think about this statistic about how we spend $5 trillion in the United States on healthcare, and unfortunately, we have some of the worst healthcare outcomes of any developed country. And then the question becomes, all right, what do we need to do about that and why? And in our particular space, in our industry, I'm not an expert like Rachael, but part of it is like the cost of medicines and the cost of interventions and the cost of drugs. And then we say, okay, well, why are the drug costs so high? And then you kind of get to that next level and you're like, well, because, it takes a lot of money to get a drug to market. And then you ask the question, why? There's somebody who does that, is like continues to ask why. Till you
The
get
5
to the
whys, I believe.
Is that may be what it is? And so you're like, okay, well, why does it cost so much to get a drug to market? And then if you look at, the developmental cost for drugs, a significant portion of that cost is in clinical trials. And then you dig into that. Well, why are clinical trials costing so much? Well, it's because it takes a lot of effort to find the right people to be part of your studies and your trials. And then you kind of get to the why there. And so I believe it's one of those things where we have to approach it from hopefully a issue and a cost that everybody should be concerned about, and then work through the whys on each one of these things till we get to something that's tangible. So what if we could reduce the time it takes and the investment that it takes to get a drug to market in half? And what if we could do that within the next 5 years. Kind of gets really interesting when you look at the macroeconomic implications of that.
Yeah.
Well, and not only that, I think it's also what's the cost of having to re-sample and retest your drug when you don't get it right the first time, right? Like there's all those examples of having to go back and look at like warfarin and Coumadin in Asian Americans and albuterol in African American children, right? There's a human cost there, but then also there's millions of dollars because you have to go back and resample to get your indication reapproved.
And even before that, if you mess up feasibility and you're not picking the right sites and you have to go back in 6 months and do feasibility again, you're already wasting money and resources and time.
Yeah. Well, I wanted you guys to go first in part because I knew you were going to go macro, but then you led right to what I wanted. And it's the thing that in doing diversity planning, which has been so exciting because we had talked about it. It wasn't just about the numbers. It's about really understanding the population. If you understand the population and you plan ahead for the right sites, perhaps this isn't as difficult as everybody thinks, what have you. But the really cool thing in diversity planning has been a few times we have found stuff in the literature or in the data that then inform the trial. So the trial was better. And in one case, we found a subpopulation within the Hispanic population that was, I don't remember the exact numbers, but it was near twice as likely to have this condition. So sponsor actually shifted where they placed their trials and recruited, I think it was 24% faster because of that. And before they weren't even looking at that data, and it was right there to be found in the literature. And if you think about it, you can't, how do you enroll a trial? How do you develop medicine if you don't truly understand your population? So this is where, doing that upfront background, not just on the disease epidemiology writ large, but how does it play out in different demographics? Mm-hmm. And that was just one example, but there's many more where I think you would have had faster, cheaper drug development with that kind of expertise up front.
Thank you. All right, I got one more question for y'all, and then if anybody in the audience would like to ask a question, I will let them. So we did a lot of, I like to call a little bit of kvetching, because last panel we get to complain about what we want. But ending on a message of hope and kind of optimism. Where do we go from here? What's next? How do you keep the mojo moving and reclaim that why and help move it forward? And you can go in whatever order you so choose, not longitudinal.
I hinted to this earlier. Part of my talk I gave was around kind of like how this is the best of times, the worst of times, and how a lot of the argument is like doom and gloom, and oh my gosh, diversity initiatives are being dismantled, and but I actually see it as an opportunity for us. I think we had enough opportunity to gather some data to really understand what works and what actually moves the needle, and now void of having leadership on a regulatory front. I can say that because I can do that without being fired. It gives us a chance, I think, for the industry now to say, if this is important and this has business implications for us, what do we need to do instead of taking the lead and waiting for a fedora, and guidance to be finalized on the DAPs? Why don't we go ahead and figure out what we need to do? And we have seen, particularly in the last quarter, as a company, we've had a record quarter last quarter, and that's because we believe that the industry is finally saying, we're not going to wait on the regulatory environment. We're going to do this work. I'm not saying everybody's leaning in, but enough of the industry is doing that now where I think we're going to see more progress being made with this approach than one that was actually being led by the FDA. And I think some people are surprised to hear that, but that's what I believe we're seeing in the early indication.
I would say we're moving towards actionable outcomes, right? Not just talking about the problems and the issues, but really thinking about actionable steps that we can take to move forward, and who all needs to be involved in those steps and how that needs to be communicated across the board so that we can all align. Yeah, but definitely moving towards things that we can take action towards, forgetting, again, the slogans, all the optics, but what are things that we can actually do? And obviously metrics and accountability have to be front and center.
So, from a hopeful standpoint, we still are having conversations with sponsors about the importance of representativeness. and that even if they aren't necessarily requiring DAPs, at the end of the day, it is still an approvability issue, whether your trial has produced generalizable data. And that conversation still gets attention. I think there's still a desire to understand your population. I think it's incumbent on those of us who have been engaged in this and embedded it. There are people that, and I'm coming from an operational perspective, I'm not in the community, out there in that way, but from an operational perspective, if we keep making sure people understand what the population looks like and keep kind of tracking those goals, that you still can get there. Because I don't know that the ones that were working on diversity truly, it wasn't a requirement yet. No one's, it hasn't been, but there are more and more post-marketing commitments for these trials that are just woefully and underrepresented and stuff. So I think the good news is by the time a lot of the trials that have gone into place with the goals start to net out, there's some enduring work there from that representation theme. I think you're going to see it continue.
So in the absence of leadership from government, the industry is deciding to lead on its own in a way. So that's good, right? All right. I had a few minutes. Does anybody want to ask a question? You stayed all day. Anybody going once, going twice? Thank you, panel. Thank you for hanging in with me. Thank you for color coordinating with me. It has been an experience.
Thank you.
Thank you.